Welcome to Chapter 16, Osteoporosis and Bone Health. If you've ever lived in a house with termites or know of someone who has, you are probably familiar with what they can do to the foundation of a home. The process of osteoporosis is similar to what happens during a termite infestation in a home's foundation. Over time, the internal architecture of bone is eroded as a result of a number of factors that eventually increase your risk of fracture. The term osteopenia, or lone bone mass, refers to a condition of reduced bone density that has not yet progressed to osteoporosis. It is the most common disease affecting the skeleton and is one of the most important public health issues affecting America. Moreover, over 50% of women and 25% of men over the age of 50 will suffer an osteoporotic fracture at some point in their lives. Fracturing a bone is a serious complication of osteoporosis. An estimated 20% of people who fracture a hip die within 1 year due to complications of the broken bone or the surgery to repair it. There is good news though. Because osteoporosis progresses slowly, you can take a number of steps throughout your life to reduce your risk of developing it. In adulthood, the skeleton remains relatively stable but is still constantly undergoing a process called bone remodeling, in which bone repairs and replaces itself roughly the same amount. With normal aging, bone breakdown outpaces replacement, causing up to 1% of bone to be lost per year after the age of 30, and this is something that we have talked about before. Other conditions such as estrogen loss from menopause or reduced testosterone in men, an overactive thyroid gland, diabetes, certain autoimmune diseases and cancers, as well as gastrointestinal disorders like celiac disease or irritable bowel syndrome, may increase bone breakdown and slow down bone replacement, causing further overall loss of bone. On the other hand, pharmaceutical agents that stop the breakdown of bone, as well as physical activity which causes bone to be built, can cause a net bone gain. Because bone is a dynamic tissue throughout life, strategies to slow bone breakdown and even build new, stronger bone are useful at any life stage. Some of the factors you can control and others you cannot. On the left side of the scale are factors that have positive influence on bone, such as physical activity, adequate calcium intake, vitamin D and protein intake, as well as hormonal balance. And on the right-hand side, the scale includes negative influences on bone, including smoking, sedentary living, poor diet, excessive alcohol consumption, and loss of estrogen. And looking at smoking and poor diet, excessive alcohol consumption, these are really things that are going to be kind of leaching those good things out of the bone. The calcium, they're going to be kind of robbing the bone of the nutrients that it needs to kind of complete that process of rebuilding. I like this acronym ACSS. This is an easy way to remember those osteoporosis risk factors, including alcohol use, corticosteroid use, low calcium and estrogen, smoking and sedentary living. So just try to remember, especially like on an exam or a quiz, when you're asked about factors that might increase risk of osteoporosis, just think of this term ACSS, or this acronym ACSS. As with anything, there are other factors to consider that we cannot control for osteoporosis. Obviously, you cannot control things like being female or having a family history or being Caucasian or Asian. Moreover, there are factors that you may be able to control, such as loss of menstrual periods not related to menopause. This is called amenorrhea. And amenorrhea is something that can happen to females if they don't have, for example, enough body fat. Let's take maybe a younger athlete, a female long distance runner who maybe is not getting enough calories in her diet to supplement the amount of calories she's expending. She may be one who is facing amenorrhea, or the loss of a menstrual cycle. Anorexia or bulimia, again, we're just not getting those calories, we're not getting the nutrients that we need. Prolonged use of certain medications in the presence of other chronic diseases such as heart disease, high blood pressure, or high cholesterol related to poor lifestyle choices or obesity. Near or at the onset of menopause, typically around age 50, women's bodies start to produce less estrogen. And this loss of estrogen can cause the bone to be lost 2 to 5 times more quickly than bone loss as a result of age alone. Although estrogen and hormone therapy have been shown to be effective or to effectively stop menopause-related bone loss, many women choose not to take hormones because of the history of breast cancer or other concerns, such as potential increased risk for heart attack and stroke. So, if you're familiar at all with breast cancer, the estrogen receptors within the breast tissue kind of really feed off of the presence of estrogen. And so, if you're trying to use the estrogen therapy to prevent the bone loss, in the same light of this is the fact that that estrogen may be helping to target those receptor sites, and if there is any cancerous tissue nearby, it's going to help make it grow or metastasize. So most of the options for maintaining normal hormone levels are drug related, but some behaviors can also influence hormone levels. In particular, you should avoid excessive exercise training coupled with strict dieting. Now, this is kind of like what I was just talking about with amenorrhea. Women who exercise excessively and restrict their eating are prone to disturbances in their menstrual cycle as a result of low estrogen levels caused by low energy availability. Essentially, you need to consume enough calories each day to support the amounts of exercise you do. A healthy, well-balanced diet should provide the necessary building blocks for healthy bones. Calcium is a critical mineral for bone health, and the body strongly defends its blood levels of calcium. Humans are not very good at moving calcium from the food eaten into the bloodstream, and this gets worse as we age. Therefore, dietary calcium recommendations also increase with age. For adults, studies show that calcium intake at or above recommended levels is not going to increase bone density, but is very important in preventing bone loss over time. It is important to note, though, that excessive calcium intake could contribute to kidney stone formation in certain people, and taking more than 2,500 milligrams per day should be avoided. This is just table 16.1, which shows the recommended daily values for dietary intake of calcium for birth to over 51 years old, as well as for women who are pregnant or breastfeeding or lactating. Additionally, Table 16.2 provides estimations of calcium for different food items. For instance, 1 cup of milk is going to yield approximately 300 milligrams of calcium. Thus, for an adult who needs roughly 1,000 to 1,200 milligrams per day, this is roughly going to equate to 30 to 40% of the recommended dietary intake for the day. Vitamin D is another nutrient important to bone health because it helps the body absorb and store calcium. Low vitamin D levels are related to low bone density and increased risk of fractures. The recommended intake of vitamin D is 600 international units for adults and pregnant or lactating women. However, the recommendation is 800 international units for adults over the age of 70. And this can be obtained from food and sunlight. Based on recent research studies linking vitamin D supplementation to reduce risk of fractures and some chronic diseases. Vitamin D is referred to as the sunshine vitamin because when UV rays from the sun make contact with the skin, vitamin D is formed. Minimal sun exposure of only about 15 to 20 minutes per day is usually going to be enough to get the needed daily vitamin D, although the ability does decline with age. We've talked about how especially older adults who are spending more time inside aren't really getting that exposure, and depending on what their diet may consist of, they might be lacking that vitamin D intake. And so overall, we're seeing that nationwide vitamin D is definitely a vitamin that is not really being consumed in the amounts and quantities that it should. And we also learned in the Alzheimer chapter that vitamin D does play a role in the onset of dementia as well. So vitamin D is actually a very, very important vitamin, something that would be good to supplement with. Table 16.3 shows various vitamin D levels in selected foods such as eggs, salmon, and yogurt. If you look there at salmon, you see that it's going to yield about 450 IU. That's one reason why the recommendation is to eat things like salmon at least once a week, just because of the sheer amount of vitamin D that it offers. We also know that they offer good fats, omega-3s, omega-6s, that are going to help to combat a lot of those chronic diseases that we've been discussing throughout the semester. Another important item for preventing osteoporosis is the macronutrient protein. Protein makes up about half of the volume of the bone and 1/3 of its mass. Research has shown both pros and cons about protein in the diet and the impact on bone health, but really it's the amount of protein that matters. Protein helps balance hormones and improves absorption of calcium from food. Very high protein diets can cause too much calcium to be lost in the urine, but very low protein diets going to hamper the body's ability to grow and repair the bone. Research has shown that increasing protein along with fruits and vegetables in the diet is the best approach for keeping calcium loss at a minimum. Protein intake requirements are based on a person's body weight because of the wide variation in lean mass based on body size, and we have talked about this in class as well. The Table 16.4 lists protein requirements based on nitrogen balance studies across the lifespan. We have discussed, if you look at the adults here, it says 19 plus of age is going to be about 0.8 grams per kilogram per day. And many of you guys have talked about, well, I thought it was at least 1.0 or 1.2. And again, it really depends on who you are, how physically active you are, and what your goals are training wise. And that's how then you would try to determine how much grams per kilogram you should be ingesting. We know that exercise can improve bone health by increasing bone mass or by slowly or preventing age-related bone loss. Exercise is also important for fall prevention, and certain types of exercise have been shown to lower fall risk. To realize the potential benefits of exercise, some precautions should be considered. First, if a person has been diagnosed with osteoporosis, even if they have not yet experienced a fracture, they should avoid activities that put high stresses on the bone, such as jumping or deep forward trunk flexion exercises. Regular brisk walking with hills as tolerated, combined with resistance training to improve balance and muscle strength, may reduce fall risk in lieu of high-impact training methods. Exercise training after hip fracture and surgery has been found to significantly increase strength, functional ability, and balance, as well as to reduce fall-related behavioral and emotional problems in elderly people. Generally speaking, these programs begin with safe range of motion activities and muscle strengthening exercises for muscles surrounding the hips, trunk, pelvis, and lower body. Typically, exercise recommendations include avoiding activities that can damage the new hip or loosen its parts. Additionally, resistance exercises that include hip abduction or adduction should be avoided initially to prevent dislocation of the new hip. And remember those terms, abduction is moving an appendage away from the body, the midline, and then adduction is moving that appendage closer to the midline or the body. The best program for improving bone health is one that incorporates multiple types of activity, including musculoskeletal, cardiorespiratory, and metabolic health. A multimodal program can provide multiple benefits and reduce the risk of injury. Additionally, applying appropriate rest periods is very essential to allow bone to be responsive to the next loading bout. And that is one of the main things that needs to be considered when prescribing this exercise, is making sure that appropriate rest periods are in there so that bone can actually remodel. If it's overloaded, overstimulated, it's going to continue to want to break down. Moderate to vigorous exercise can improve or maintain bone mass of the hip and spine and has additional benefits to the cardiovascular, muscular, and nervous systems. To challenge the skeleton and thus signal bone building, the aerobic exercise should be weight-bearing. The general recommendation for aerobic exercise aimed to improve bone health is to reach a minimum target of 30 minutes of continuous moderate intensity exercise 5 days a week for a total of 150 minutes. So this is similar to what we're seeing for just an adult, right? So we're shooting for the same amount of minutes. Resistance training can also have a positive effect on bone because of strong muscle contractions required to lift, push or pull a heavy weight across puts stress on the bones, and that's something we've also discussed in class, right? The arms, the legs, they all work as levers. So we have the muscles that are attached to the bones via the tendons, and when those muscles contract, they pull on the tendons, which then pull on the bones, and it's that pulling, that stress that's induced on the bone that causes it to go ahead and remodel. So this can be done using weight machines, free weights, elastic tubing, weighted vests, or elastic bands. Strong muscles can also contribute to better balance and locomotion, which can reduce the risk of falls. And remember, it's really important to try to reduce the risk of falling, because someone who is osteoporotic, if they fall, and depending on what type of surface they fall on or how they land, that can make the difference between a fractured bone or not. For example, take Grandma Margaret. Grandma Margaret fell a couple winters ago down feeding her horses when she was, 80, well, that would have been like 88 years old, down feeding her horses. And she falls and she landed on her elbow on a board, and her ulna just busted right there because she's osteoporotic and the surface she landed on was hard, and she pretty much put most of her weight there on her elbow. So a lot of things come into play there, but the goal is to reduce the risk of falling so that we don't have a fracture occur. Resistance exercise, like aerobic exercise, must be slightly vigorous to affect bone. It is recommended to do resistance training 2 times a week, including 2 to 3 sets and 8 to 12 reps. And then, so again, that's similar to what we're going to see as prescribed for a healthy adult. Additionally, a person should try to do most of their resistance training while standing, as it's going to engage the smaller stability muscles, and it's going to overall be more functional for them. Stretching at least 2 to 3 days per week should be a part of an exercise program to maintain and improve flexibility and joint mobility. In addition to reduce risk of fall and subsequent fracture, we know that a person should be engaging in that neuromotor training. Make sure that the proprioception is intact as best as possible. So Table 16.5 is providing a sample multimodal program for those with osteoporosis. Just something to look at where they have, we're seeing aerobic, resistance, and flexibility training as well as the fit prescription there. That would be something easy to look at and use if you are working with a grandparent, for instance. You could use that kind of as a guide. And then figure 19.3 is a weekly multimodal beginner exercise program with those for osteoporosis. And this is something that some of you guys might have jumped ahead and looked at when you were working on your program design lab. But this is something else to look at just for getting an idea of exercises to prescribe that would be appropriate for individuals like this. Medical treatment that reduces the risk of fracture is important, and there's new drugs that are continually being developed and new formulations of current drugs that are being made to improve the effectiveness while reducing side effects. Most of the drugs currently approved by the U.S. FDA for the management of postmenopausal osteoporosis are called anti-resorptives, and they are going to increase bone density by rendering the cells that break down the bone inactive while leaving alone those that form the bone. So they're trying to increase the rate of bone buildup and decrease the rate of, well, not necessarily increase the rate of bone buildup, but they're definitely trying to decrease the rate of bone breakdown. And drugs in the drugs in this category are going to include estrogens, calcitonin, bisphosphonates, denosumab, and selective estrogen receptor modulators. Bisphosphonates are currently the most widely used for reducing osteoporotic fractures. On average, these drugs increase bone density by 48% at the spine and 1 to 3% at the hip over the first 3 to 4 years of treatment. A small increase actually can reduce the risk of vertebral fractures by 40 to 50%, and non-vertebral fractures, such as the hip, by as much as 20 to 40%. While they are promising in reducing fracture risk, new studies are kind of questioning their long-term safety. These drugs remain in the skeleton for decades, and bone turnover can be effective for up to 5 years after the drugs are discontinued. So if bisphosphonates prevent breakdown and bone renewal, the concern is that bone could actually become brittle. Experts have not come to a concrete consensus on how long bisphosphonate therapy should be continued, but some preliminary clinical recommendations state that 3 to 5 years of treatment is probably sufficient for someone with a mild risk factor. Based on the risk factor, so a high risk factor or a low risk factor, this recommendation may go up or down accordingly. And then 2 other therapies, hormone therapy, which is a combination of estrogen and progesterone, and then estrogen therapy, which is the offset, which is used, both of these, the hormone therapy, again, which is a combination of estrogen and progesterone, and then estrogen therapy. These both offset the estrogen-related bone loss associated with menopause and even cause a slight increase in hip and spine bone density that plateaus after 3 years of use. So the use of hormone therapy and estrogen therapy have been shown to reduce the incidence of fractures of the hip and spine by about 30 to 50%. But to be most effective, most of the use of these should probably begin close to, if not a few years before the menopausal transition. And lastly, selective estrogen receptor modulators, or SERMs, represent a class of agents that, although similar to estrogen, exert their effects only on target tissues. The overall effect of SERMs is a little bit more modest compared to that of bisphosphonates. Thus, it's recommended for women with milder osteoporosis or for those with osteoporosis primarily in the spine. So each person's health history is unique, and so really the choice of medication should be made with a healthcare provider in light of the total health situation. And Table 16.6 lists the pros and cons of common osteoporosis medications that should be considered prior to beginning therapy of any kind. And just as a kind of an end note here, you do not need to memorize these drug classes. I want you to be kind of familiar with how bisphosphonates, for example, kind of how they work, what their purpose is. Same with estrogen therapy, hormone therapy, SERMs. Those are the 4 that I think you need to be kind of familiar with. You don't need to know the specifics of them, what the pros or cons are, but maybe just be familiar with kind of what they were created for, what they are doing to try to kind of decrease the risk of fractures in general. Okay, so that kind of wraps up chapter 16, which is osteoporosis and bone health. I hope that this has been helpful, and I hope that it is something that you can utilize as you're studying and starting to prepare for our final exam. All right, take care, and we will be in touch.